Okay, good. Thank you. So I think we're good to go, 16 people. And today's quiz, we will start. The topic is different obstetric scenarios. So as I said, as an obstetrician, and also when you're giving the exam, whenever you face an obstetric scenario, there are two questions that come to your mind. So whenever someone asks you, how will you manage this patient in obstetrics? What are the two things that should strike you? The two things that should strike you are, when should I deliver this patient should be the first question. Okay, so you get a question on preeclampsia, eclampsia, GDM, IUGR, whatever scenario is given to you, and you're asked obstetric management. The two questions that should flash straight away are, when should I deliver this patient? And the second question is, how should I deliver this patient, right? So by when, it means by at what period of gestation, right? And how, you only have two routes. We either have a vaginal delivery or a cesarean section, right? So these two, if you are able to answer, that is the entire obstetrics summed up. Okay, so obstetrics is actually quite simple. If you understand the concepts, if you understand what can go wrong, what are the possible complications, if you keep into consideration both the mother and the baby, and then you will understand when to deliver. And how to deliver depends again on what complications can happen, and hence, and how urgently you want the delivery to happen. Hence, you decide whether it's a vaginal delivery or a cesarean section. So obstetrics, entire obstetrics can be as simple as two questions: when and how. So today's quiz is on when. When, or that means when do we determine the period of gestation? When does the patient need to deliver? When should we deliver this patient? Okay, so we will start now, 17 people, and I think we're all good to go. Okay, so just note on the pin in case you get logged out, you can quickly log in again. All right. So I'm starting. Okay, go. I'm starting. Don't disappear again. All right. Okay. So the quiz on when to deliver. Good luck. Okay, so I've given 1 minute for each question because they're all clinical questions. You can read carefully and then answer. So the first question is, a 19-year-old primey, 31 weeks, headache, epigastric pain, BP is 180, 100, platelet count 60,000, SGOT 700. What is the next best step? Usually I don't give 1 minute, but because they're clinical questions, I thought it's best to properly read, analyze, and then answer. So always it's asked in the exam, the next best step. So there may be 2 or 3 or maybe 2 options which are very similar, but always choose the best step. All right. You may not be wrong. So another option may be very close, but you're always asked the best step. Yes, the correct answer is magnesium sulfate, corticosteroids, and planned delivery. Now, I'm not going to discuss this right now because we have 3 questions on hypertension, and then we will discuss this all in the end. Is that okay? Is that how we should go about it, or you want me to discuss this question individually here right now? I think we'll finish hypertension and then discuss another 2 questions or 3 questions, I think, and then we will discuss. All right. So, okay, so someone is typing whole topic, ma'am. Okay, so hypertension at the end we will discuss. Okay, so the answer to this question is, we'll give magnesium sulfate, corticosteroids, and plan delivery. All right, so let's see the scoreboard. The scoreboard is Sampath on top, PKC 500, KK Prayan. Okay, next question. Not able to open in mobile the MCQs. I'm not able to understand the MCQ. The question will appear on top on the Zoom. Sampath, if you have any doubt, the question should appear on top, and you should be able to mark color coded A, B, C, or D. All right. And you've scored on the first question. You're number 1 right now. So I think you've sorted that out. Okay. Next question. Question number 2. A 24-year-old primey presents at 28 with seizures. Her blood pressure is 150 by 108. The next best step is. Always the next best step is asked. Quickly answer. So time also does matter in getting on top of the scoreboard. But I've given a longer time because they're all clinical questions. Okay, yes. So magnesium sulfate and immediate delivery. So if you mark D, immediate delivery, that's not wrong. But you have to choose the next best step amongst all those are given. You have to choose the next best step. And why the first two are wrong, all that you'll understand better once we do the discussion. All right. Okay, so Avinash, welcome on top. Then KK Sampath, PKC and 518. All right, next question. Question number 3. 24-year-old primey, 36 weeks with a blood pressure of 140 by 90. Uterus is term, fetal heart is present. Urine albumin is 3+. CBC, LFT are normal. When should she be delivered? She's 36 weeks right now. A few parameters are given. Oh, sorry, the time was less in this. Okay, anyway. But most of you got this right, 37 weeks. All right, so now I think we'll switch to the discussion on hypertension and pregnancy. I think this was the last question, if I'm not wrong. So we'll quickly shift to the discussion. Okay. And then we'll continue with the quiz. Okay, so hypertension and pregnancy. 1 second. Okay, so these are the topics we have lined up: hypertension, diabetes, liver disorders, FGR, post-acute multiple, and varicella. These are the questions we have. Okay, so there's just some changes. Briefly, I thought before discussing directly management, what is preeclampsia? This is the definition of preeclampsia. Okay, so what is the definition of preeclampsia? What was it is if the blood pressure is more than 140 by 90. Okay, 1 second. Let me just get my pen. So it's a blood pressure of more than 140 by 90 after 20 weeks. Okay. And proteinuria. Okay. But please remember in ACOG 2018, the guidelines have slightly changed. Proteinuria may not be essential. Okay. So if proteinuria is, then how much proteinuria? 300 milligram per 24-hour sample, or a 1+ or more dipstick, or a protein creat ratio of more than or equal to 0.3. So blood pressure plus proteinuria is equal to preeclampsia, is what you have all been taught, and all of us know this. Okay, but what has recently changed, I put this for that, in the absence of proteinuria. So there may be a patient whose blood pressure is say 150 by 100. She comes at 26 weeks. Okay, but you find there is no proteinuria, but you find there is thrombocytopenia, platelet count less than 100,000, or you find the serum creat is 1.2 or 1.3, or you find there is increased SGOT, SGPT, or you find there is pulmonary edema, or you find that she has headache or visual disturbances. So in the absence of proteinuria, if you find evidence of end organ damage, okay, then that means she can still be labeled as preeclampsia. In gestational hypertension, you won't find any of these features. These are seen only in preeclampsia. Hence, even if proteinuria is absent, you can still label the woman as preeclamptic. Okay, that is because the proteinuria happens because of glomerular endotheliosis. So the kidney may actually not be affected in some patients. The organ affected may be different, and hence the definition has changed. And we do also see many patients who come like this. So this I just put so that you know that proteinuria is no longer essential in the diagnosis if there are other features present. Now, we have two types of preeclampsia. You know that this is essential to know because you should be able to know this to answer questions. One is preeclampsia without severe features, which was earlier known as mild preeclampsia, and one is with severe features. Okay, and what are those severe features? If the BP is more than 160 by 110, if the creat is more than 1.1 or more than two times the baseline levels, if the transaminases SGOT, SGPT are more than or equal to two times the upper limit of normal, which is usually taken as 72. Okay, if there is new onset headache or blurring of vision, or if the platelet count is less than 1 lakh, or if there is pulmonary edema. So if any of these are there, okay, then it is called as preeclampsia with severe features. It was earlier called as severe preeclampsia, and the other group was called as mild preeclampsia. Now it's called preeclampsia without severe features and with severe features. So you should be able to understand that if any of these are given in your question, it becomes severe preeclampsia with severe features, and your management will change, especially the timing of delivery. That is why this is essential. Now, management when do you deliver? Okay, this is very important, this slide. So if you have gestational hypertension and preeclampsia without severe features or mild preeclampsia, then we terminate at 37 weeks. So I am telling you this with reference to, one second, with reference to ACOG guidelines 2018 is my reference. Okay, some books may still not include this, but most of your questions will get asked based on recent guidelines, and this is the reference for that. Okay, not much has changed in the earlier guidelines, so it's not much of a difference, but remember that gestation hypertension 37 weeks, preeclampsia without severe features 37 weeks. Okay, preeclampsia with severe features, if those severe features which I mentioned are there, you terminate at 34 weeks. But there are certain indications where you may even have to terminate earlier than 34 weeks. What are those indications? If there is uncontrolled severe range of BP, despite her being on maximum antihypertensive drugs, there is still uncontrolled BP, then we may have to terminate even before 34 weeks. If there is refractory headache is not responding to your management, or she has epigastric pain, which is a sign of stretching of the liver capsule, and she can end up with a rupture. So that is again a sign where you cannot wait any longer, or if she has a stroke or a myocardial infarction, or if she has features of HELP syndrome. What is that? Hemolysis, elevated liver enzyme, or low platelet count. Both partial, that means some features are there, or complete HELP. 2 features or 3 features are there. We will still terminate before 34 weeks. Worsening renal dysfunction. Say she has one feature on amongst the severe features. 1.2 is a creat. But after 2 days, you repeat it is now 1.5. So she's now worsening and she's not yet 34 weeks. You can't wait till she goes into full-blown renal failure. You have to terminate her. Pulmonary edema, it's a severe sign. It is also a sign of terminating before 34 weeks. Fetal distress, you do a Doppler and you find there is absence or reversal of diastolic flow at 32 weeks. If you wait till 34, you'll end up losing the baby. So you can consider termination earlier. All right. So these are indications of earlier. And whenever the question is less than 34 weeks, please remember, if the indication is not immediate, then give time for corticosteroids. Okay, what does corticosteroids do? For fetal lung maturity. Okay. Also, if she is less than 32 weeks and you plan to deliver her, give time for magnesium sulfate, because in hypertension, it acts 2 ways. One is it before 32 weeks, why? It causes neuroprotection of the fetus. Okay. And secondly, even if more than 32 weeks, you would want to give it for prophylaxis of eclampsia. If the woman has imminent signs, she's having headache, blurring of vision, vomiting, then, or if her BP is very high, then you will give, and you're planning to deliver, give her prophylactic magnesium sulfate to prevent eclampsia. Okay. So corticosteroids, remember, less than 34 weeks. Okay. And any preterm, forget about hypertension, any preterm less than 32 weeks, magnesium sulfate should be given for fetal neuroprotection. Okay. And there is also a separate category. When will you wait for nothing? You won't wait for steroids. You won't wait for magnesium sulfate. You will, 28-week patient comes with eclampsia. You won't wait for anything. You will directly give magnesium sulfate for stopping the seizure, not neuroprotection, but stopping the seizure, and then immediately terminate her. Same with abruption. So you cannot wait for corticosteroids to act and say after 48 hours I will deliver her. So immediate indications are eclampsia and abruption. Otherwise, 34 weeks or earlier if you have any of these features. Okay, and without severe features, mild and gestational, terminate. Once she reaches term, terminate the pregnancy. Okay, so I hope this is clear. Hypertension in pregnancy, when do you need to terminate? Okay, so anything less than 34 weeks, give corticosteroids. If she's having severe preeclampsia or eclampsia, give magnesium sulfate also. If she's less than 32 weeks for neuroprotection, give magnesium sulfate. This is not only for hypertension. Neuroprotection and corticosteroids are for all complications. Less than 34 weeks, magnesium sulfate, corticosteroids, less than 32 weeks, magnesium sulfate. Is this clear? Voice is not, you can't hear me. Yadav is saying he can't, he or she can't hear me. Can you hear me? Am I audible? Breaks in between. Okay. So let me try with the mic again. A second. Okay. Clear. Someone is saying, let me just wear my mic and see if that's better. Okay. Is it better with my mic? Is it better? iPhone says yes. V says clear. Now is it clear with my mic? Okay. Pratmesh is saying yes. Okay, yes, yes. Okay, everybody. Okay, so am I clear? I will repeat once again. Gestational hypertension, mild preeclampsia, 37 weeks. Preeclampsia with severe features, 34 weeks. Earlier, if you have any of these features, and immediate termination if there's eclampsia or abruption. If less than 34 weeks, in any scenario in obstetrics, if you have time, give corticosteroids. Less than 32 weeks, if you have time, give magnesium sulfate for neuroprotection. In eclampsia and severe preeclampsia, give magnesium sulfate for prevention of eclampsia also. Okay. So am I clear? Yes. Okay. Any doubts? Let me know. Side by side, you can enter the chat box. Let's switch back to the quiz. Okay. Switching back to the quiz. Get ready, guys. Okay. So I'm not sure if the next question is hypertension or not, but if okay, so Avinash remains on top. Okay, so slight change. Let's go to the next question. You might have one more hypertension. No, diabetes. Okay. 34-year-old G2 with overt diabetes, well controlled on insulin at 34 weeks. When will you plan induction of labor? Can you please mute? I will answer your doubts. Okay, so I can't review the questions now. I can't go back. Okay, but we can review them in the end once. Please mute, Dr. Manish. Please mute. Dr. Manish, please mute. 34-year-old with overt diabetes, well controlled on insulin at 34 weeks. When will you plan induction of labor? This is a previous year recall. It's a little controversial also. Yes, it is 38 weeks. Okay, so we will discuss this. Okay, someone had a doubt in between. In HELP syndrome, will we deliver immediately or give tocolysis for steroids to act? So in HELP syndrome, yes, you will wait for steroids to act for 48 hours. Okay, and then you will tocolysis you'll give only if she's going into preterm labor. Otherwise, you don't need to give tocolysis if she's not in labor. You will give time for steroids to act in HELP syndrome, and then you will terminate. So ideally, if you get a question on HELP syndrome, give steroids, give magnesium sulfate, and then you deliver her. Okay, I think that was the one of the questions also. Okay, so we'll discuss GDM also. Let's go to the next question. Scoreboard. Okay, Avinash has gone down, KK is on top. Okay, next question. 26-year-old primey with GDM is now 37 weeks. She is on diabetic diet and her sugars are well controlled. When will you deliver her? 37, 38, 40, 41. GDM on diet, sugars are well controlled. When will you deliver her?
Okay, those who are answering on the chat box, are you unable to answer on Kahoot? Yes, 40 weeks. Good. Most of you got this right. Are you unable to answer on Kahoot, or you're just messaging me separately? If you're unable to answer on Kahoot, then it's okay. If there's any issue on Kahoot, let me know. Okay, so this is correct. The answer is 40 weeks. Okay, next question. There's one more on GDM, then we'll put the discussion. Okay, AKK Pran Avinash, top 3. Next question. 24-year-old primey with GDM is at 33 weeks. She's on metformin and her FPS, PPBS is this much, 144 T08, 208. What is the next best management? Will you immediately induce her at 34 weeks, induction of labor after controlling sugars, or induction of labor at 37 weeks? Again, next best management. You may not get, you may think there's something else better, but amongst the options given, what would you do? Okay, what will you do? What will you do? Some people aren't answering. Okay, answering quickly. Okay, so you will plan induction at 37 weeks. Okay, so ideally you will control her sugars, and after sugars control, you will still plan induction at 37 weeks. You will not prematurely induce her just because her sugars are not under control. Okay, so let us go to the discussion. Let's see the scoreboard first. Okay, Prion on top, Avinash, KK, Priya, Kriti. Okay, so let's see the discussion quickly. One slide I think only we have on GDM. Let me go to that. Okay, so diabetes in pregnancy. So again, I'm giving a reference for everything. So why my references are ACOG, you may wonder, is because our standard book is Williams, okay? And Williams follows American guidelines. And whenever your examiners, faculty who prepare your exams for the national board, they're asked to give standard references. So all the faculty from the national board prepare questions from, with the standard reference being Williams. So you're supposed to follow ACOG guidelines. Other guidelines may say something else, but ideally we follow ACOG guidelines when we prepare questions for the NB, and I have prepared questions for the NB. That's why I am saying this. Okay, so ACOG Practice Bulletin 2018 updated guidelines on GDM says the following. So what does ACOG say on GDM? Forget over diabetes. Let's just talk about GDM first. Okay, what do they say for GDM? On diet, what should you do? So if a patient is there, please silence. Divya, please mute. Okay, so someone's asking overt diabetes meaning. Okay, so let me go back to basics. When we talk about diabetes in pregnancy, we have two types of diabetes. We have what is called as pre-gestational diabetes or overt diabetes. That is, the woman is already diabetic. She either has type 1 or type 2 diabetes, and then she becomes pregnant. That is called as pre-gestational or overt diabetes. The second type of diabetes is gestational diabetes. That is diabetes detected for the first time when she is pregnant. Okay, can you mute the participants? I know I am unable to. Somehow I tried doing that. Isliye my request, Divya is saying sorry. My request is please keep yourself on mute so we can understand better. Okay, so pre-gestational or overt diabetes is diabetes which has started before she's pregnant. So a woman who's, she may or may not know it, but this is diabetes which is before pregnancy. Okay, GDM is diabetes which develops during pregnancy. Okay, so the etiology of both is different and management also slightly differs. Okay, now let's talk about GDM first. Gestational diabetes, that is diabetes developing during pregnancy. Okay, say at 24 weeks you do a GTT and you find that she is diabetic. Then what do you do? Okay, so if the woman has GDM but is controlled on diet, then there's nothing much to worry. We can wait up till 40 weeks is appropriate with antepartum testing. So we will terminate or induce labor at 40 weeks of gestation. We can wait till 40 weeks. There's no harm waiting till 40 weeks if her diabetes is controlled on diet. If she is well controlled GDM on medication. That means she's either insulin or on metformin. Usually these are the two drugs we give to control diabetes. So, and she's well controlled. Then we can deliver at 39 weeks. If 39 weeks is not given as an option, like in the question, then 38 weeks is the best option to mark. This is given in some books, and this has come as an earlier question, as an earlier recall. That's why I put this question directly. 39 was not mentioned, but 38 weeks is the closest answer, and many of the Indian books give this as the answer. So deliver at 39 weeks is what ACOG says. But if you don't have 39, then 38 weeks. You will not go till 40 weeks in a woman who is on insulin or on metformin if she is diabetic. Okay, and the third is third category is poorly controlled. So if she is poorly controlled diabetic, you will deliver her between 37 to 39 weeks, depending on other factors like the fetal status. Okay, so a safe answer would be 37 weeks. Please remember, if she's uncontrolled, like the last question we discussed, uncontrolled diabetes terminate at 37 weeks or earlier if there is failure of inpatient hospital or in-hospital glycemic control, or if there's abnormal, there's some problem in the fetus, there is IUGR or macrosomia or whatever. Okay, we may decide to terminate earlier. Okay, but remember, it goes downwards. She's on diet 40, she's on medication, metformin or insulin 38, 39. This is well controlled. So diet, well controlled, medication, not well controlled, 37. You can terminate anytime after 37 weeks. Okay, is this clear? This is for GDM. If she has, okay, one more thing you need to know. Can you just hold? I have to take an important call. Just sorry, my daughter's teacher was calling. Okay, so going back, right. So one more thing important, if you get a question on GDM with fetal weight more than 4.5 kg, then because of the risk of shoulder dystocia, you should counsel the patient for an elective LSCS. Okay, irrespective of everything else, if 4.5 kg is the fetal weight on ultrasound estimation, counsel her for elective LSCS because of the risk of shoulder dystocia. Now, when it comes to overt diabetes, that means the woman is already diabetic. She may or may not be on treatment. Usually such patients will be on insulin. Okay, so she's overt, she's previously diabetic on insulin. Then what do? You do an elective delivery between 37 to 39 weeks. So if you you'll usually get 38 weeks as the correct answer in this question. So overt diabetic with no complications on insulin, mark 38 weeks. Guidelines say 37 to 39 weeks is correct, but the best option would obviously be then 38 weeks. This has also come as a previous year recall. Okay, so remember 40, remember it like this: 40, 39, 37, 38, 39 and 37. If she is GDM, this is the three categories. You have diet, well controlled medication, poorly controlled medication. Okay, and if she's over diabetes and no other complication, take her till 37 to 39 weeks. Best answer would be 38 weeks, and then deliver her. So only on diet, if she is, we take the woman till 40 weeks. Everywhere else, we deliver 1 or 2 weeks earlier. Am I clear on this? This is a very, very important topic. Previous year questions come. It's a controversial topic. Everywhere, different things are given. In every book I've seen, Marrow gives something, TAMS gives something. But this is according to ACOG guidelines. And these are the correct answers as far as the guidelines are concerned. Okay, so if somebody makes your question seeing the guidelines, this is what needs to be followed. And usually they won't give something very close. The answers will be pretty far apart. So usually that confusion or controversy should not arise. Okay, so nobody will ask you 37 and 38 dono option nahi honge. over diabetes mein. It will be either 36 or 38 or 40. It will be like that. Okay. So I hope this is clear. Let me see anyone have any doubts. Okay, FPS more than how much do we consider as diabetes? If it's 92 or anything, ma'am. Okay, so FPS, so how diagnosing diabetes is a separate topic altogether. And if you want, I will discuss that. We have different guidelines. We have what we follow is the IAD PSG guidelines, which is done in two phases. One in the first trimester, and then later at 24 to 28 weeks. In the first trimester, why do we do testing? To check on any patient who might be overt diabetic. She may be overt, but she doesn't know. So in the first trimester, we do testing. And how we do the testing? We do an FPS, or we do a HbA1c, or we do an RBS. And at 24 to 28 weeks, we do a OGTT. Okay, so I'm not sure of the value of FPS. I don't think it's 92. I think it's 105, but let me check and I'll get back to you, Sampath. Okay. Sampath, you're directly messaging me. Okay. Ask in INICT. FPS more than 92 it is. They were saying 92. Okay, then you guys are right, 92. But let me just check. But for FPS testing is done only in the first trimester with RBS and HbA1c, and GTT is done, 75 gram GTT is done, 0 hour, 1 hour and 2 hour is done at 24 to 28 weeks. Okay. 92 is correct. Okay, so 92 more than FPS more than 92 is correct, is what everybody is saying. Okay, so let's go back to the quiz. Okay. Okay, so Prayan has scored 3 correct answers in a row. Okay, so next question, everybody get ready again on your Kahoot apps. 32-year-old, now RH negative, 32 weeks, she's A negative, ICT is 1 in 64, MCA, PSP is more than 1.5. What is the next best step? Okay, Avinash has asked a question. I will just answer it once this is over. Yes. Okay. So this is RH negative. She has her ICT is positive. PSP is more than 1.5. So the correct answer, you'll do an ultrasound guided quadricentesis and IU intrauterine transfusion if required. That's the correct answer. We'll discuss why. Does that change the scoreboard? Avinash is on top. So Avinash, your question is how does the management of GDM on insulin differ from overt diabetes on insulin? The answer is it doesn't differ much. You still have to terminate between 37 to 39 weeks either. So if a woman, if you get the question diabetes in pregnancy on insulin, when will you terminate? The answer is between 37 to 39 weeks, ideally 38 weeks. Okay. Next question. Okay, again RH negative, 34-year-old G2 at 36 weeks, her blood group is B negative and her ICT is negative. When will you plan delivery? She is RH negative, ICT is also negative. 37, 38, 40, 41. Quickly, all of you answer. Easy question this is. Okay, so surprisingly, so this is a simple question. She's just an RH negative pregnancy. There's nothing else given here. So why will you terminate so early? The idea behind RH negative is you will not let her go post date. So you will wait till 40 weeks. You will not let her go beyond 40 weeks. There's no other complication given. You can easily wait till 40 weeks till if she goes into labor, otherwise induce at 40 weeks. The main idea is you will not let her go post dated. Okay. So that should change the scoreboard a bit. We'll discuss all this in a while. Okay. No change in the scoreboard. Okay. So, 1 second. Kingu is the highest climber, up 3 places. All right. Next question. Last question on RH negative, then we'll do the discussion. 26-year-old B negative at 36 weeks. Her ICT is 1 in 32 and Doppler shows a PSV of more than 1.5. What is the next best step? See the question carefully. She is B negative at 36 weeks. ICT is 1 in 32. MCA is more than 1.5. What will you do? See the first question, RH negative, and see this question. What's the difference? Yes, you will induce labor. PDF is available. Okay, Sampath, I will make the PDF of the questions. Okay, don't worry about that. Also, I'll be putting this up on YouTube. Okay, so the next best step is induction of labor. What was the difference between the first question and this question? The first was 32 weeks, right? So now she's 36 weeks. So she's crossed 34 weeks. So 34 weeks is like the golden line in obstetrics. Beyond 34 weeks, we're not that worried about fetal lung maturity. What is the main risk of a preterm, taking out a preterm fetus is respiratory distress syndrome. The lungs are not developed. So that is our concern. Less than 34 weeks. See, in obstetrics, there is basically a play between giving a healthy mother and a healthy fetus. So you have to weigh your risks and benefits of taking out a preterm infant. Why are we wary about delivering before 37 weeks? Because we are worried about preterm, but that risk is higher if she's less than 34 weeks. So you have a complicated pregnancy. ICT is positive. MCA Doppler is PSV more than 1.5 means there is redistribution of blood. There is fetal anemia. This MCA Doppler more than 1.5 moms means that there is fetal anemia. There is fetal anemia. She's crossed 34 weeks. Then there is no point waiting. But the same scenario was given at 32 weeks. Then yes, taking out a 32-week baby compared to taking out a 36 weeks baby, there's a lot of difference. That's why 32 weeks you would want to give cordocentesis, give her bias some more time till she crosses 34 weeks, give her corticosteroids and then deliver her. Okay, so I hope that's clear. We'll quickly do a bit of a discussion also. Okay, Divya is saying please discuss all the questions at last. That means discuss with each question or at the end of the quiz. Do I discuss with each question? Is that what you mean? Okay, at the end of the quiz, everybody agrees. Pratmesh is also saying at the end of the quiz. Okay, let's do that then. You don't like this breaking in between? Let's do that. I'm okay with both. Whatever you guys want. Okay, so I'll discuss at the end of the quiz. Let's move on then. Quickly finish the quiz and do the discussion. Okay. But then don't leave in between, huh? And I'm talking to a blank screen. I don't want that to happen also. Okay, so Kriti has entered the scoreboard. Avinash is on top. Okay, at the end. Okay, everybody's like at the end. But then if you guys walk out on me now, then I'll be very upset. Okay, 24-year-old primary at 34 weeks with itching on the palms and soles. She's mildly icteric and bile acid levels are raised. What is the next best management? Answer quickly. Yes. So this is what is the diagnosis? It is obstetric cholestasis. Prion is on top. Obstetric cholestasis. We deliver at 38 weeks. All right. So that is why the answer was that. Okay. Next question. 23-year-old with twin pregnancy, 31 weeks, complains of abdominal pain and nausea. She is icteric. Bilirubin is 6. AST is 450. RBS is 44. What is the best management? Twins, 31 weeks, pain, nausea, icterus, bilirubin, AST are raised, RBS is 44. What will you do? Yes, this is what is the diagnosis? Can anyone write in the chat box quickly? What is the diagnosis? Okay, so PKC enters the scene. What is the diagnosis? Quickly tell me. Yes, good iPhone. Acute fatty liver or good Pratvesh. Acute fatty liver of pregnancy is the diagnosis. So the treatment is immediate termination of pregnancy. Next question. 21-year-old primary fetal growth restriction at 30 weeks. This is her umbilical artery Doppler. What is the next best step? FGR 30 weeks, umbilical artery Doppler is given. What will you do next? Okay, yes. So this Doppler is actually normal and hence we won't terminate her. We will do weekly Dopplers of the umbilical artery. All right. Next question. So let's see the scoreboard. Okay, 518 has entered. Okay, and has a streak of correct answers. Okay, 30-year-old G2 with previous LSCS presents at 33 weeks with fetal growth restriction. This is her umbilical artery Doppler. What is the next best management option? Previous LSCS, 33 weeks with FGR, and this is the Doppler. Yes, that's the correct answer. Corticosteroids followed by LSCS. This Doppler showed absence of end-diastolic flow, which is an indication for termination of pregnancy. But since she's less than 34 weeks, we will want to give her steroids and then do the cesarean section. So please remember, 34 weeks, if it is not an urgent, immediate decision, unless it's eclampsia or abruption or something which requires urgent termination where you can't even wait for a second, then you don't have time to give. But otherwise, if you have time, give corticosteroids and then terminate the pregnancy. Okay, so does that change the scoreboard? Okay, slight change in positions. Prion remains on top. Okay, next question. 22-year-old low risk gravidae 2 is at 40 weeks 2 days. She is sure of her LMP and has a first trimester scan which is corresponding. What is the next best step? So she's 40 weeks 2 days. What will you do next? Will you do a modified BPP, induce labor, reassure her, and ask her to come after 1 week, or do a DFMC? What is the next best step? You'll do a modified biophysical profile. Okay, and we'll discuss this. She's basically gone beyond her EDD. So once she goes beyond, a patient goes beyond the EDD, you have to initiate antepartum fetal surveillance. And the two antepartum fetal surveillance choices given are DFMC and a modified BPP. A modified BPP is always better. The AFI has to be seen once she crosses 40 weeks. Okay, so that is why this is the correct answer. Okay, we'll discuss this also later. Okay, slide shift in positions again. Okay, next question. 40-year-old primary conceived after IVF presents at 36 weeks with DCDA twins. The first twin is breech. What is your plan? Quickly answer. Yes. Okay. So why won't you do an ECV? Because she's multiple pregnancies. It's a contraindication to doing an ECV. And DCDA twins are the twins which has the lowest risk. So we terminate twin pregnancies which are DCDA at 38 weeks. Okay. Does that change the scoreboard? Not at all. Okay. Next question. 32-year-old at 32 weeks with monochorionic monoamniotic twin pregnancy. When and how should delivery be planned? Easy question, quickly answer. I think I want all of you to get this right. MCMA twin pregnancy, when and how should delivery be planned? Elective LSCS at 34 weeks. Remember, she's monochorionic monoamniotic twin. What happens in MCMA twins? Because they're in the same amniotic cavity, there is cord entanglement. If the two cords, umbilical cords of both the fetuses get entangled, there can be blood supply cut off to one or both the twins, and sudden IUDs are at a very, very high incidence. So MCMA are always terminated at 34 weeks. We do not go beyond 34 weeks in monochorionic monoamniotic twins because of the very high incidence of cord entanglement. So please remember this point. Okay. Slide change. Avinash comes on number 2. Okay. So I think last 3 questions. Let me see. Yeah. 26-year-old, 32 weeks with painless vaginal bleeding. She had a similar episode at 28 weeks. Her vitals are stable. Fetal heart is present. What is the next best management? Yes, everybody got this right. Almost everybody. I'm glad. So this was placenta previa, and we will follow conservative management or McAfee Johnson's line of management in this patient. Okay. No change, I'm sure. Okay, everybody got this. Okay, next question. 34-year-old, 30 weeks with bleeding per vagina. BP is 140/90. Uterus is tense, 32 week size. Fetal heart rate is 100 beats per minute. What is the next best step? Quickly, answer. Yes, so emergency LSCS. Why? So what is the diagnosis here? This is abruption. And in abruption, there is as light as like eclampsia. There is no time at all. You have to deliver the patient. Otherwise, there could be very high incidence of maternal and fetal complications. Already the fetal heart is 100 beats per minute. There is fetal distress. So this is abruption with fetal distress. The best way to deliver such a patient would be to do an emergency LSCS. If the fetal heart was all right, the answer would have been induction of labor. So if fetal heart was 140, slight change of this question, the answer would have been induction of labor. But either way, you have to terminate the pregnancy. Okay. Most got this right. I'm glad. Slight changes in position. Okay. Last question, I think. No, last two questions. 24-year-old lady at 38 weeks presents with fever and rash suggestive of varicella zoster. What is the next best step? Infections in pregnancy. This is a very important question. Varicella at 38 weeks. What will you do? Yes, so basically this question is commonly asked, and it's also there to confuse you a bit, because whenever a woman has varicella or chickenpox at term, the main idea is don't let her deliver. Let the rash subside. Give her at least, if you can buy time, 7 days ka time you need between onset of rash and her delivery. Why? Because there's a very high risk. If she delivers now, the baby will develop neonatal varicella, which can be fatal. Okay, so you have to buy time for antibodies in the mother to develop, and hence transfer those antibodies to the fetus in utero before she delivers. Okay, so hence if it's unpreventable and she's in labor already, you can't do anything. But at this point, nowhere is it mentioned she's in labor. She's 38 weeks. She's come with fever and rash. You need to just give her symptomatic management and wait, preferably for at least 7 days, and then only plan her delivery. By that time, there will be enough antibodies in utero and the fetus will have protection against neonatal varicella. And also, if by chance she delivers, then of course you'll give immunoglobulin to the fetus, but try and prevent delivery is the main thing you should remember in varicella. Okay. Slight change. 518 and KK exchange places. Okay, and last question. I think this is on prom. Yeah, 32-year-old G2 at 31 weeks with leaking. The uterus is relaxed. What is the next best plan of management? She comes with preterm pre-labor rupture of membranes. Okay. The correct answer is B, yes. So preterm pre-labor rupture of membranes, you will give antibiotics to prevent chorioamnionitis. You will give corticosteroids. Okay, you may give trocholysis till the time corticosteroids are given, and then you will induce labor between 34 to 36 weeks. You will not wait beyond that because you're just simply increasing the chance of her getting infected. Okay, so again, we will wait till 34 weeks. Why 34 weeks? Because that is the cutoff for most of our complications. All right, because by then fetal lung maturity is attained. So let's see the scoreboard, the podium. Okay, so number 3 is, okay, 110. Okay, Avinash, sorry. Number 2 is Ranoband and number 1 is Brian with 15 correct answers. Very good. Congratulations, Brian. Runners up KK and 518. Okay, so good. So should we go to the discussion? Yes, quickly, 10 minutes, we'll finish the discussion. The main hypertension diabetes is anyway over. Okay, so let's go to the discussion. 1 second. One second. Any cash prize to the winners, ma'am Sampath? No, I'm sorry. I am doing this for free. And maybe when I get some money, yes, I will give some cash prizes. But the aim of this is to help you guys for your exams. Okay. Pratmesh, is ma'am is taking quiz enough. He's just joking. Don't worry, Pratmesh. Okay, and Pratmesh, by the way, thanks to Pratmesh for giving me this idea to do this quiz, this topic. Okay, I had seen it not been covered in one place anywhere, and I thought it's a good idea to know when to deliver what. So obstetric clinical scenarios in one place, I tried to put together. Okay. So your cash prize will be scoring well in your NEET PG exam. That is the best prize anyone can get. And I hope this helps you to reach there. Okay, that is my aim. Okay, so let me continue now. Okay, so RH negative pregnancy. So I have an entire lecture on RH negative pregnancy. So I'll quickly, briefly tell you about RH negative pregnancy in the form of a flow chart. Okay. All right. Okay, so why isn't this starting? Okay, so the scenario is we have an RH negative mother and an RH positive father. Okay, so this is the scenario which leads to an RH negative pregnancy, right? So what happens is, what is the first thing we can do? We can offer, okay, so this is something which is extra, okay, not given in most of your books, but it's a new guideline. Okay, so what is the first thing we can do? We can offer paternal genotype and cell-free DNA if heterozygous. What does this mean for those of you who are not able to understand? if the mother is Rh negative, okay, that means she doesn't have the D antigen. Okay, so suppose her husband is or partner is Rh positive, then he can either be heterozygous or homozygous for it, right? That either he has the D antigen 1 or both, that would make him heterozygous or homozygous. Either way, he is Rh positive. All right. So if we do the paternal, if we do the husband or partner's genotype, okay, and we find he is homozygous, okay, then obviously 100% of their fetuses or their offspring will definitely be Rh positive. So then there's no point of doing this cell-free DNA. Okay, but suppose the husband's on karyotype, we find he is heterozygous for the D antigen. Then there is a 50% chance this offspring is actually Rh negative and 50% chance the offspring is Rh positive. So if we do a cell-free DNA or what is called a NIPT, you must have read about this in Down syndrome screening. We take a blood sample from the mother. There are fetal DNA inside the maternal blood. And we do look for the cell-free DNA and see if the fetus is Rh negative or Rh positive. So if the fetus is Rh negative, it saves us a whole lot of worry and a whole lot of testing for the mother, because we know now that our baby is Rh negative, nothing is going to happen. This pregnancy is low risk completely. But if the fetus is Rh positive 50% of the time, if the father is heterozygous, then we resort to all these testing. But of course, this is not routinely done in India because of the cost. It is to be offered to all women. Sorry, it is not recommended in the US also, but it should be, the patient should be told that this is an option. If they want to go ahead, according to ACOG, this option should be given to the parents, that this option is also there if they want to go ahead with it. It is not to be done compulsorily in all patients. So I hope this is clear. This is something which is new. It is a use of cell-free DNA. NIPT is not only for Down syndrome, it can be used for determining the fetal Rh positive or negative status also. Okay. Now going to the main thing, you have an Rh, say a patient comes in the OPD, she's B negative, husband is A positive. What is the first thing you do? The first thing we do is a booking indirect Coombs test, and ICT will tell us basically if she's isoimmunized or not. Okay, so I'm not going to the details, the basics, all that is in my YouTube lecture. You can check that out. But let us just quickly go to the simple management. What will you do in the OPDs? So there are two scenarios. The ICT is negative. That means she is not isoimmunized. She doesn't have antibodies against the D antigen. So what will you do? You will repeat the ICT 4 weekly every month. Or if you don't do it every month, at least at 28 weeks and at 34 weeks. Why 28 weeks? Because we give anti-D at 28 weeks. Prophylactic anti-D we give at 28 weeks and we repeat at 34 weeks. Okay. If the ICT continues to be negative, give her anti-D at 28 weeks, deliver by 40 weeks. Do not go beyond 40 weeks. Okay. And give anti-D if the fetus is Rh positive. Okay, so I hope this is clear. This part is clear if the ICT is negative. The other problem which can happen is if the fetus, if the mother is ICT positive. This is what we are worried about. That means she is now isoimmunized. So we see the titer. The titer with what is called the critical titer is 1 in 16. Less than 1 in 16 is not significant. It is, we know she's isoimmunized, but the antibodies are not enough to cause fetal anemia. That is the meaning of less than 1 in 16. So if the ICT is positive, but the titer is less than 1 in 16, what do we do? Okay, we can again offer her, okay, forget this step, we'll just go down. Okay, we can repeat the ICT 4 weekly. Okay, so what do we do if ICT is positive? Keep repeating it every month till 24 weeks, then every week till the critical titer is reached. Okay, so we are basically worried about the critical titer because that is now when we know the antibodies will start destroying the fetal red cells and can cause fetal anemia. So we keep repeating the ICT till the critical titer is reached. Suppose the ICT remains negative, remains less than the critical titer. Okay, then we deliver at 37 weeks. So I hope you understood this point. ICT positive, but less than 1 in 16. We keep repeating the ICT. Sorry, something went wrong. We keep repeating the ICTs monthly till 24 weeks, then weekly thereafter, okay, till the critical titer is reached. If the ICT remains less than the critical titer, we deliver at 37 weeks. So basically, we know that she is she's isoimmunized, but she's not at risk of developing fetal anemia. Okay, now the next scenario is the ICT now becomes more than 1 in 16. That is, it is more than the critical titer. What does this mean? There's a risk of developing fetal anemia. Okay, so now what do we start doing? From 24-week onwards, we start doing a middle cerebral artery peak systolic velocity every 1 to 2 weeks. What does this tell us? So whenever there's fetal anemia, there is redistribution of blood to the more important organs in the body. So from the liver, from the abdomen, the blood will get redistributed and more blood will now flow to the fetal brain. Okay, so this is one vessel which is easily accessible on the ultrasound, and if we do a peak systolic velocity of the middle cerebral artery on the ultrasound, we can see that if the PSV is rising, that means more blood flow is going to the brain. That means there is evidence, indirect evidence of fetal anemia. What was done earlier, 20-30 years back, what was done? MCA Doppler was not easily available. Okay, ultrasounds came only in the 80s. Okay, and Dopplers came much later. So Lilly's curve or Lilly's graph amniocentesis was done where bilirubin levels were determined in the amniotic fluid. But nowadays we do a MCA PSV. Okay, so if the PSV is more than 1.5 moms, what does that mean? That means there is fetal anemia. So what do we do? If she is, one second, if she is more than 34 weeks, what do? We deliver her. So we know she's ICT positive and there is evidence of fetal anemia. She's crossed 34 weeks. We are not at all, we are now pretty comfortable. The fetus's lungs are mature. So we will not wait any longer and we will deliver her. This was the question in the quiz. But if she's less than 34 weeks, then we need to buy time for fetal maturity to be attained. So what do? We do a cordocentesis, ultrasound guided. That is, we put a needle in the umbilical vein, take out a sample of fetal blood, see if the fetus is anemic, that is if the hematocrit is less than 30, and then do a intrauterine transfusion. We keep doing this till she reaches 34 weeks. We keep doing this every week till she reaches 34 weeks, and then we deliver her. Okay, so this is clear. Okay, but if the PSV remains less than 1.5 moms, what do? We repeat the PSV weekly, okay, and till it reaches here or till she reaches 37 weeks when we terminate pregnancy. Okay, so is this clear? So our main aim is to determine fetal anemia. Fetal anemia is there. We deliver her if she's more than 34 weeks. Otherwise, we give intrauterine blood transfusions. If there is ICT positive, but there is no evidence of fetal anemia, then we can take her till 37 weeks, of course, with repeating PSV MCAs weekly. So this is clear. There's a very more descriptive lecture on YouTube. You can go through that for Rh negative pregnancy. Very important topic in the exam. Many of you get confused in this. Okay, if ICT is positive, but titers are within normal limits. Okay, that means less than the critical titer. So if ICT, that's what I said, if ICT is positive, but less than the critical titer, exactly what I said, Avinash. See, I'll just go back. Okay, so if I want to go back. So what we'll do is we will terminate at 37 weeks because ICTs are positive, but the, one second, let me just, sorry, excuse me. Okay, so as I said, here's the flowchart for that, okay. So here ICT is positive and suppose the ICT remains less than 1 is 16. That means there is isoimmunization, but not enough for the, one second, yeah, this now gets a little disturbing sometimes. Yeah, so here, so ICT remains less than 1 in 16. What happens is that means she is isoimmunized. There are antibodies against the D antigen in the maternal serum, but they are not enough to cause fetal anemia. So we're not that worried. Okay, so we take her till 37 weeks. Same if it has crossed the critical titer, but the MCA PSV remains less than 1.5, then also we take her till 37 weeks. But if there is evidence of MCA PSV more than 1.5 moms, here is where we are concerned, and here is where we either deliver her or we do a cordocentesis. So it's actually very simple. If you understand this flow chart, it's very simple. You just have to go step by step. First do an ICT. If that is more than the critical titer, then start doing MCA PSVs. If that crosses 1.5, then start doing intrauterine transfusions, cordocentesis, but only if she's less than 34 weeks. Our main aim is to get her beyond 34 weeks. If less than that, we have to do intrauterine transfusion. Okay, next topic, easy topic, obstetric cholestasis. What do? We give symptomatic relief. Okay, what is the risk of obstetric cholestasis? We are worried about sudden intrauterine death. Why? Because bile acids are increased in the blood. Okay, and this can cause vasospasm of the umbilical artery, and sudden IUD can happen. Many times the patient comes to us with no complaints, no decreased fetal movements, nothing, and you find there's an IUD. So because we're worried about the sudden IUD, we terminate at 38 weeks. All the rest are for symptomatic relief. Ursodeoxycholic acid is one of the main management drugs in management, but the final management is of delivery at 38 weeks. RCOG says after 37 weeks, ACOG says after 38 weeks. This is what we will follow. Okay. And of course, fetal monitoring, PTINR, if it is prolonged, give vitamin K, weekly LFTs have to be done. All this has to be done. Okay. I'm sure all of you know obstetric cholestasis. Is not much more to know in that. Okay. Acute fatty liver of pregnancy, also known as acute fatty metamorphosis. It is the most frequent cause of acute liver failure during pregnancy. Important point. AFLP has come several times in the exam. 1 in 1,000 pregnancies you need to remember, because it is a previous year question. Okay. So this is also a previous year question. Association with preeclampsia with twin pregnancy. The scenario I gave was twin pregnancy with male fetus and with primary gravid women. Clinical features usually presents in the third trimester. There will be pain and nausea, vomiting. There will be progressive jaundice, fetal distress, and fetal death. It has a high perinatal and maternal mortality. Okay, investigations. What you need to remember is liver function tests are abnormal. Okay, what is abnormal? You will find bilirubin is raised, but usually less than 10. Enzymes are raised, but usually less than 1,000, as against viral hepatitis, where bilirubin will be more than 10 and enzymes will be more than 1,000. But characteristic features, you'll have hypoglycemia. Okay, remember hypoglycemia in AFLP. This is characteristic of AFLP. All right. Also remember, coagulation parameters are deranged. Patient can go into full-blown DIC. What is the management? Immediate delivery. Okay. Delivery will arrest the liver dysfunction and is the main mode of management, along with intensive care support. Okay. It has a poor perinatal and maternal outcome. Okay. Now FGR, tell me what is this? This is normal? Yes. Okay. Someone's asking a question. Okay. AFLP and hepatitis can be differentiated only by lab values, mainly by lab values. Yes. Okay. Mainly by lab values. As I said, bilirubin levels are less than 10 and SGOT, SGT are less than 1,000. And also you won't find features of DIC. Coagulation abnormalities will not be there until very late in viral hepatitis. Okay. They'll usually settle. Okay. Also perinatal mortality is not high, maternal mortality is not high, but there is it is usually viral hepatitis will settle down with medical management. AFLP will keep getting worse until you deliver the patient. Okay. If he's asked also, Avinash, ICT is positive and tight, so that I answered. Okay. Then someone else has asked, AFLP associated with repeated abortions. No, AFLP is not associated with the repeated abortions. Also, the recurrence in AFLP in recurrent pregnancies is not very common. Okay, but Sampath, I will get back to you on that. I don't think it is associated with repeated abortions. Pratmesh, yes, viral antigens will also be negative, of course, in viral hepatitis. Okay, now coming to FGR, this is a normal umbilical artery Doppler. Okay, so what happens in FGR? This part starts going down. This is the systole. This is the diastole. So the diastole starts going down. So there's initially reduced diastolic flow. Okay.